Okay, I would like to welcome everyone to the Vasculitis Foundation webinar today. I'm Kathy Olewski. I'm the host for the Vasculitis Foundation's educational webinar series, but I'm also a patient living with MPA vasculitis. These webinars are part of the Vasculitis Foundation's commitment to patient education, and we'd like to thank our sponsor, Novartis, for supporting the webinars. Today's webinar is Testing and Monitoring During Remission with Dr. Guy Katz. After we finish the webinar today, there'll be a recorded version on the Vasculitis Foundation's YouTube channel, and everyone who's registered will receive an email with a link to it as soon as it becomes available. I'd love to introduce our speaker for today. We have with us Dr. Guy Katz. He's a rheumatologist and clinician investigator in the Division of Rheumatology, Allergy, and Immunology at the Massachusetts General Hospital in Boston, and an instructor in medicine at Harvard Medical School. He's a member of the MGH Rheumatology and Allergy Clinical Epidemiology Research Program and MGH Rheumatology Vasculitis Program and MGH IG4 Related Disease Center. So thank you so much for being with us today, Dr. Katz. We appreciate you and we're looking forward to your presentation.
Thank you so much for the introduction. I'm really excited to talk about this. I think this is a topic that bears or begs a lot of questions for a lot of patients and providers. So I do have some slides to talk about just kind of general things related to remission and vasculitis, but I'm excited to be able to answer many of your questions. And I have to say, it's so nice to see some of your faces on the actual Zoom chat. So I'm looking forward to having a good conversation here. Let me
Well,
pull
we
up my. Oh,
Well, we're
sorry,
going
go
to
ahead.
actually launch the polls first, if that's
Oh,
okay,
that's
and
right.
ask
Yeah,
ask the audience a few questions, and then we'll have you do your presentation. So
that sounds
I
great.
I hope everyone can at this point see that we've put a few questions in here. We'd love participation from you. So if you get a chance to just look at these four questions and answer what you can, everything's anonymous. We're not using them for anything other than to see who's here and let Dr. Katz have an idea of what your situation is. Okay, good. I am going to now end the poll so that I can share the results with all of you and let Dr. Katz take a look and see what he thinks of some of these answers.
So these are really interesting answers, and I think they're sort of in line with what we would expect. So here in the first question, have you ever experienced remission from vasculitis? A slight majority, but a majority are currently in remission, and then another 21% have been in remission but have relapsed. And this is very much in line with what I would expect to see. I would say that at any given moment, most of my patients with vasculitis, fortunately, are in remission, or have been in remission in the past and just kind of need additional therapy now. And for the most part, it's really just people at the very beginning of the disease who haven't been in remission yet, and hopefully will be soon thereafter. So that is in line with what I would have expected to see. Um, and also in line with what I'd expect to see is most people who enter remission seem to be in remission for anywhere between 6 months and over 3 years. Um, and that's very much in line with what we'd expect to see. And it very much depends on the type of vasculitis that you have as well. Um, what treatments people have been on, medications. Almost everybody has been on medications, combination of treatments. Some lifestyle changes have been helpful in maintaining remission, which I think is a really interesting thing to see. Um, and Here, I think, is a really interesting part of the discussion, which hopefully we'll have some time to talk about today, is what does remission mean to you? And we can see quite a bit of variation in how people responded to this. Some people felt that remission means no symptoms at all. Some people think that some symptoms are okay during remission, but that they need to be manageable. And then some people talked about fewer flares, less severe disease, ability to return to normal daily activities. So I think there's quite a bit of variation here in terms of how people think about vasculitis, or excuse me, think about remission in vasculitis. So I'm looking forward to being able to delve into that a little bit more in detail.
Well, thank you so much for giving us your thoughts on that. I just want to make sure that we all had a chance to see the results, and we did, and you had a chance to comment. And I would love for you to start sharing your presentation with us now so we can learn more about how to about this topic, about what you do while you're in remission.
Absolutely. Are you able to see my slides?
Yes.
Perfect. Okay, so I will move through this quickly because Kathy very kindly introduced me and this topic. So the slides that I put together are mostly related to testing and monitoring during remission. There's, of course, other things to think about during remission related to disease control and things like that. And if questions come up related to that, I'm more than happy to discuss it. But these slides are mostly related to the testing and the way that we monitor people who are in remission from vasculitis. I do have some disclosures. I don't think any of them are particularly relevant to what we'll be talking about today. So the objectives for the next 15 minutes or so will be to propose a definition of remission in vasculitis, to discuss considerations for how we monitor the disease during remission, and particularly in some of the most common types of vasculitis, though again, we can talk about some other types afterwards in the question and answer session. And we'll also discuss some treatment-related testing and monitoring during remission in vasculitis. So first, let's talk about some definitions. Here, there was a lot of variation in how the participants today thought about remission in vasculitis. And I think that makes sense because it's not as easy to conceptualize as it is kind of in the general sense of the word remission. So when most people think about remission, they immediately think about cancer. They think about the oncology definition of remission, which is usually assessed after a patient with cancer has completed some sort of treatment, maybe some combination of surgery, chemotherapy, radiation, immunotherapy. And it's defined in the oncology space as there's no detectable evidence of the tumor cells at any place in the body. And of course, a person can be in remission and then can come out of remission afterwards if it looks like there's recurrence of the cancer. The way we define it in immune-mediated disease is more complex, and it's different, and it's disease dependent. And this is true for vasculitis, but it's also true for most other autoimmune diseases where the definition depends on the disease and can be interpreted in a few different ways. So generally speaking, the way we think about remission in vasculitis, patients may be on or off treatment at the time that you're assessing for remission. And typically, we think about people as being on little to no steroids or glucocorticoids, things like prednisone, either being on no prednisone or a very low dose. And the reason for that is for most vasculitis syndromes, and this is true for most autoimmune diseases in general, if you're on a high enough dose of prednisone, there won't be any active disease, or there will be very minimal active disease. So the goal is not to show that the prednisone has worked, but rather to show that we've controlled the disease without having to rely on prednisone, which is a medication that's very broadly anti-inflammatory, but also has a lot of long-term risks. So it's usually not the way that we manage diseases long-term when we can get away with it. And the way we really define it is no detectable evidence of active disease based on a combination of symptoms, physical exam findings, laboratory values, and imaging, depending on the exact clinical situation. There's a huge caveat to this, which is that symptoms or physical exam or lab abnormalities that result from damage from prior active disease can still be present when someone's in remission. And we'll go over some examples of that. But one very common example is in someone who has, for example, kidney failure from ANCA-associated vasculitis, let's say MPA or GPA. If they have kidney failure that happens, when they're initially diagnosed with the disease, very often the kidney failure will not recover, or it will not recover fully. Even when the patient is in remission and there's absolutely no evidence of active disease, there's still some evidence of damage to the kidney. The same thing can happen in just about any other site of involvement from vasculitis, where there's a certain amount of damage that happens to the area, and the damage may still lead to some symptoms or some other problems down the road. That shouldn't be confused with active disease, which is manifestations that are from ongoing inflammation in the blood vessels or other tissues. So that's why it's important to recognize that when we talk about remission, we're really talking about, is there um, evidence of active inflammation? That if we were to biopsy the area of involvement, wherever we think that's involved, would we see still ongoing cells indicative of inflammation, or would it look like there's scar tissue formation and kind of remodeling of the area from prior inflammation, but no active inflammation? And here are a few examples. I put together 4 examples of what remission could look like in 4 different diseases. So the first one is a patient with giant cell arteritis who initially had headaches, scalp tenderness, jaw pain with chewing, which is called jaw claudication, and vision loss in the right eye. The patient was initially treated with high doses of prednisone and started on tocilizumab. Um, and now we're seeing the patient in the clinic. They've been off prednisone for 6 months, still on tocilizumab, and the vision unfortunately never returned, which we would consider to be damage. But all of the other symptoms of the disease have completely resolved. So this is a patient who is in remission, but on treatment. The next patient is a patient with Takayasu's arteritis, who initially had fatigue, arm pain with use, which is called arm claudication, and imaging of the blood vessels in the chest and abdomen showed that there was wall thickening, narrowing, and occlusions. Occlusions meaning there's no blood flow that's able to actually get through the artery. And this patient was treated with prednisone and had to go through multiple different medication regimens, but finally was able to be on infliximab infusions and methotrexate and has been off prednisone for about a year. The imaging findings have been stable for about a year. Though the occlusions that were present, meaning the areas where blood flow wasn't able to get through the arteries, those occlusions never opened back up, suggesting that it's again damage. It's from remodeling and scar tissue of the blood vessels rather than from ongoing inflammation. The markers of inflammation are normal. The other symptoms, including the symptoms from like the arm pain with use, that has been improving. Physical therapy is improving that as well. Though because there's ongoing symptoms for that, surgery is planned to be able to restore some of the blood flow to the arms related to those occlusions. So these are 2 patients who would be considered to be in remission, both on treatment. The next one's very different. This is a patient with IgA vasculitis who initially came in with blood in the urine. The kidney function was reduced. There was a rash all over the arms and legs. There was significant joint pain and swelling, abdominal pain. The patient was quite sick when this first started, but was only treated with a 4-week course of prednisone. And that seemed to control everything. Now the patient has been off treatment for 6 months. The symptoms have resolved entirely. The kidney function is entirely normal. So this is now a patient who's off treatment in remission with no evidence of ongoing disease and also no evidence of damage from the disease. And that's great. And the last patient is a patient with ANCA-associated vasculitis who initially had double vision, fever, sinus crusting, and bleeding into the lungs, and was treated with prednisone, rituximab, and avacopan, which is a newer medication that we use in ANCA-associated vasculitis. Now the patient is off prednisone and avacopan, has been on rituximab infusions every 6 months for the past year. The lungs, all of the lung abnormalities have completely normalized. The double vision has resolved, no more double vision. There's still some sinus crusting, but it's minimal and it's managed well with topical steroid sprays and saline irrigation. So this is another example of a patient who's in remission on treatment, and most of the manifestations resolved completely, but there's still some ongoing symptoms. And it's not uncommon to have that with the sinuses because once the architecture of the sinuses and the anatomy gets destroyed, the sinuses are just not able to circulate the contents of the sinuses the way that they're usually able to before they get damaged. So it's not uncommon to have some ongoing symptoms that need to be treated topically in people with a history of sinus involvement from ANCA-associated vasculitis. So these are 4 people with vasculitis in remission at different stages with different degrees of treatment. And you can imagine that each of the 4 of them has a very different quality of life, very different outlook on what their vasculitis is doing day to day. And remission just looks very different for each of the 4 of them. Now, moving on, let's talk about some of the considerations that we have during remission. And I think of it as sort of three buckets of things that we need to monitor for. We need to monitor for evidence of relapse. And that's different if someone's on treatment or off treatment. If someone is on treatment and they have a relapse, then it suggests that the treatment is failing, that some additional treatment or change in treatment is needed in order to control the disease. Whereas if someone is off treatment, then a monitor for relapse means usually that they would need to restart some sort of treatment. Second, we monitor for other complications associated with the disease itself. And third, we monitor for treatment-related toxicities or complications. And we'll talk about each of these three in more detail, starting with monitoring for relapse. So it's important to recognize that vasculitis is not one disease, as I think we all know. Vasculitis is many different diseases. And in each vasculitis, there's different risks of relapse. In some vasculitis syndromes, relapse after remission is extremely common. It is the rule rather than the exception. Examples of this are ANCA-associated vasculitis and Takayasu arteritis. These are diseases that, in the vast majority of cases, do relapse. Not everyone, particularly with ANCA-associated vasculitis. Some people might have it and then it goes away and never comes back. But a majority of people do have relapses. And in diseases like this, really close monitoring for relapse is critical, and that monitoring needs to be done quite long term. In contrast, there are some vasculitis syndromes that are very often monophasic, which you can think of as kind of one and done. Examples of this are IgA vasculitis, as one of the cases that I presented was, anti-GBM disease, polyarteritis nodosa. In many of these patients, it happens, you treat it, it goes away, and it never comes back. That being said, there's no guarantee that it's not going to come back. So it is still important to monitor for relapse. And that's for two reasons. One is, as I just mentioned, we don't know. Just because most people don't relapse doesn't mean that it won't relapse. Even in these diseases, sometimes it does relapse. But the other reason is in many of the vasculitis syndromes that we treat, there is no definitive test to confirm that we have the right diagnosis. Some of them there are definitive tests, but some of them there are not. And in those sort of cases, I always like to have a certain healthy level of uncertainty, recognizing that I think I know what's going on. I think this is polyarteritis nodosa, and I think this is going to respond in this way. But sometimes we don't have all the information about the disease the first time that it presents. And when it presents a second time with a relapse, sometimes additional information becomes available and we find out, oh, it turns out this is actually more consistent with this other disease that relapses much more frequently. So even in people who we have a pretty good sense that the likelihood of a relapse is low, we still need to monitor fairly closely to make sure that we're actually right about what we think is going on. And then the next thing that we think about is what does a relapse actually look like? And very often it is either similar or identical to previous presentation. And that is the majority of cases. But unfortunately, it's not always the case. Sometimes a disease can evolve over time and can present in different ways during a relapse. Someone with ANCA-associated vasculitis who had kidney involvement when they first presented might have eye involvement when it comes back again in the future. So because of that, we have to think about all of the different things that these diseases can do and really look out for everything, not just the things that have happened in the past. Our goal when monitoring for relapse is to identify the relapses as early as possible so that we can start treatment early and prevent complications. Many of you, I'm sure, had the experience of when this initially started, it was going on for quite some time, days, weeks, months, maybe even years before you maybe even saw a doctor for the first time for it. And then after seeing a doctor, it may have taken a long time to actually get to the diagnosis and get to starting treatment. The goal, once you have the diagnosis, is to be able to skip all of that so that as soon as there's very early evidence that the disease is coming back, we can start treatment and prevent complications from happening. And I think we tend to be much more successful at that once patients actually have a diagnosis and we know what we're looking for, as opposed to earlier on when it just takes time to even get to the underlying diagnosis. And how do we monitor for relapse? So we look for evidence of disease that resembles the initial presentation. If someone had very typical manifestations of the disease when they first presented, then we'd look for those same things. But if someone had a really atypical manifestation, something that you might not read about in a textbook, we will still look for that in follow-up to see if it's come back. Because once a disease has declared that it is able to do something in one particular person, then it's very likely or at least possible that it might happen again in the future when it relapses. So the first and easiest thing that we do is we see what the disease has done in the past, and we monitor to see if it's happening again. But we also need to monitor for other common or dangerous manifestations that we know can happen in a disease, even if it hasn't happened in the past. So an example of that is in GCA, most people don't present with all of these symptoms that I just listed, but they're all very common in the disease. So I make sure that patients with GCA that I'm taking care of are aware of all of these symptoms, even the ones that they haven't had, so that they can let me know if they happen in the future, because that might be an indication that the disease is relapsing. Similarly, with ANCA-associated vasculitis, we talked about sinus crusting. There's other things that it can affect. It can cause weakness of the hands or feet, kidney inflammation, lung inflammation, eye inflammation. So when I see patients with ANCA-associated vasculitis in follow-up, I ask about all of these symptoms, and I do blood work and urine tests to screen for some of the things that might be asymptomatic, because I'm looking for all of these things, even if they haven't happened in the past. So getting into the details a little bit more, what does monitoring for relapse actually involve? The bottom line here is it depends entirely on the disease. Usually, it's some combination of a few modalities. Asking about symptoms, as we were just talking about, some physical exam findings are important to look for. Laboratory evaluations are important in just about every type of vasculitis. And in some, though not all, imaging is important as part of the longitudinal assessment to see if there's evidence of relapse. How often? Again, it depends. It depends on the risk of relapse, the likelihood of something really bad happening if the disease were to relapse, how quickly the disease tends to evolve. There are some diseases that tend to evolve very, very slowly over time, and other diseases where someone could be doing great one day and 2 weeks later could be in the hospital. So we take that into consideration when we think about how often to screen for certain manifestations of the disease. We also think about how likely is it that someone's going to have active disease if they're asymptomatic. If it's unlikely, then we might be um, less inclined to screen really aggressively, because we know that if someone's not doing well, they're not going to feel well. Um, Similarly, time in remission and whether it's remission on or off treatment. These are all things that affect our decision making in terms of how often we're going to be monitoring and how we monitor. Um, Generally, the frequency of monitoring can range from every few weeks to yearly, and it can sometimes be even less frequent than that, particularly in people who've been in long-term remission off any treatment. Um, Especially if it's a disease that's known to have a very low risk of relapse. Once someone's been in remission for a long time off treatment, it eventually can be perfectly safe to stop monitoring. But for the rest of your life, it is important to still recognize that it's something that you had, and there's always the possibility it could come back. So to just be aware of those symptoms and to let your physician know if you're having any of the symptoms to suggest that the disease is coming back. So that's kind of how we monitor for relapse, and we can certainly go into more detail about how we do that in the Q&A session, or in other ways if it would be helpful. The next consideration that we think about is how we monitor for complications associated with the disease itself. Um, and this is certainly disease dependent and depends on a number of factors related to the underlying diseases. Um, Even if there are certain manifestations that even when the inflammatory disease is fully resolved, and we talked about this a little bit before when we were talking about damage, there are still some manifestations that can naturally worsen over time, even if the disease is in remission. And it is important to continue to monitor for those manifestations. As an example, in someone who's had kidney involvement in the past and had significant injury to the kidneys, once someone has chronic kidney disease for any reason, whether it's from vasculitis or from diabetes or from something else, the natural course of kidney disease is that it does progress over time. So in those cases, it's important to continue monitoring the kidney function. And usually people who have some degree of kidney dysfunction need to be following with a kidney doctor to make sure that that's being monitored and that anything that needs to do to address that is being done. Similarly, we talked about occlusions in the large vessels in one of the cases that I talked about. When we see narrowing in large blood vessels, that even when we resolve the inflammation, the scar tissue that happens there can sort of contract over time and can sometimes cause progressive narrowing, even when there isn't any active disease. So that's something that we continue monitoring over time. When we're getting imaging of the blood vessels, we're not just looking to see if there's active disease or no active disease, but we're also looking to see, is there any evidence of change in the areas that have been involved in the past that would suggest that we need to do some additional workup or look out for other symptoms that might occur. And then another example is when there's airway inflammation, as can happen in ANCA-associated vasculitis, for example. That's another area where the scar tissue formation can contract over time and can lead to recurrent airway narrowing, again, even when there's no active inflammation in the airways. So these are all things that need to be monitored for over time. And then there are some diseases that are associated with other diseases. So we need to look for those other diseases. The most common example of this is in GCA. GCA is very, very closely associated with another disease called polymyalgia rheumatica. And GCA, by the way, is giant cell arteritis for anyone who's not aware. Polymyalgia rheumatica is not technically a vasculitis, even though we see a lot in the vasculitis world because it's so strongly associated with giant cell arteritis. But polymyalgia rheumatica presents with pain and stiffness of the shoulders and hips. Um, Many people with PMR develop GCA later, and many people with GCA develop PMR later, and sometimes they happen at the same time. So in someone with GCA, I make sure that they're aware of the symptoms, not only of GCA, but also of PMR, and I monitor for those symptoms over time because it can happen at any point, and that's something that we continue to monitor for. Another example is in cryoglobulonemic vasculitis. Cryoglobulins are something that typically come from somewhere. Sometimes they can happen for no good reason, but very often it's something that's associated with either infections or autoimmune diseases or blood cancers. So these are things that we will screen for both in the initial stage when we're first making the diagnosis, but also longitudinally. Even in someone who's in remission, we continue to monitor to make sure that we're not missing any new symptoms or new lab abnormalities to suggest those other associated diseases. And now moving on to the last sort of bucket of how we think about monitoring in these in remission and vasculitis is we think about the treatments themselves. Most of the medications that we use in vasculitis have either short or long-term toxicities that can occur, and many of these need to be monitored regularly. That being said, these are very safe medications that we can use safely. But the way to use them the most safely is by making sure that we're monitoring for the potential complications that they can cause so that we can address them before they get even worse. The best example of a treatment that we use routinely in almost everyone with vasculitis that has a lot of potential toxicities is steroids or glucocorticoids, medications like prednisone, methylprednisolone, dexamethasone. And these medications can affect really just about any part of the body. They can anything from weight gain to eye toxicity to bone toxicity. So there's certain monitoring that we do routinely in people who are treated with long-term prednisone, and some of that monitoring even needs to continue for a certain period of time after the prednisone is completely done. And that includes things like bone density scan, monitoring cholesterol, blood pressure, screening for diabetes, and then monitoring for things like cataracts and glaucoma that happen more frequently in people who've had significant steroid exposure. I also have a list here of a whole bunch of medications that we use in a lot of different types of vasculitis. I won't read all of them, but you can see them there. I included some brand names in case that would be helpful. And these are all medications that we need to be checking blood counts, liver function, and kidney function really every 3 months, as long as you're on the medication, just to monitor for any potential toxicity from those medications. These are all medications that can, in some way, to some degree, affect either blood counts or elevate the liver enzymes, or maybe the dose needs to be changed if there's altered kidney function. So these are all medications where you need to get blood work done on a regular basis to make sure that we're not getting any toxicities. And then I'll talk about two more medications or classes of medications that have some toxicities that are particularly important, and also because they're commonly used in different types of vasculitis. The first is the group of medications called B-cell depleting agents. The most common one that we use is rituximab, but there's some others that are used as well. Um, and the way B-cell depleting agents work is they target the B cells, which are one of the cells in the immune system. That the cells related to the B cells are very involved in autoimmune disease, but also in development of antibodies, which are immunoglobulins. So these medications target those B cells and remove them from the blood. When that happens, the immunoglobulin levels over time can also go down, particularly for people who are treated with these medications on a regular basis for multiple years. Those immunoglobulin levels very often will go down progressively over time. So we do need to monitor immunoglobulin levels. If they go down uh, low enough, it can increase the risk of infection. And sometimes we do need to provide replacement immunoglobulin, which is where you receive either as injections or infusions immunoglobulins that replace what your body would be making. Um, we also sometimes monitor actual B cell counts, and this is in part to make sure that the medication is doing what it's supposed to be doing. And in some cases, it can be associated with activity of disease. So that's something that we sometimes do. Um, and generally speaking, for patients who are on B-cell depleting agents, I'll typically check their labs essentially whenever they have an infusion of their medication, which is usually every 6 months. But sometimes over time, we space it out a little bit more to every 9 months or every 12 months. So I'll at least get labs every time they go in for an infusion so that we can check on these things. And then the last medication that I'll mention is cyclophosphamide, which is not a medication that we usually use um, during remission. It's usually a medication that we use to induce remission. And then once someone's in remission, we transition from cyclophosphamide to something else because cyclophosphamide used over a long period of time has a lot of potential toxicity. But in anyone who's had exposure to cyclophosphamide in the past, um, there's the risk of things like bladder toxicity or bladder cancers, and rarely other secondary cancers as well. So in patients who've had exposure to cyclophosphamide, I try to intermittently get urine tests to see if there's any evidence of bleeding in the urine. And I also make sure that they're up to date on all of their routine cancer screening. But if they have new concerns or new symptoms, I have a lower threshold than I otherwise would to make sure that we're not missing some new secondary cancer or some other complication that may have come from the cyclophosphamide. So in summary, remission in vasculitis can look substantially different in different individuals. And it is really important to do long-term monitoring for recurrence of vasculitis manifestation. Um, the long-term monitoring might be lifelong, or it might be time limited, depending on the history and the type of vasculitis we're dealing with. And the frequency and manner of monitoring really depends on many factors related to the disease, related to the person, how it's manifested in the past. We often monitor for long-term complications related to the disease itself and diseases associated with the vasculitis. And most treatments for vasculitis also require some degree of monitoring even during remission. Some of that monitoring might even need to be continued after the medication is stopped. So I'll stop there. I appreciate the attention, and I would love to transition to take some of your questions now.
Well, thank you, Dr. Katz. That was really informative and already answered a lot of the questions that I had, but we are getting questions from some of our patients, so I'll go ahead and start
Great.
with some of those. This first one is so common. I would love to hear your response on it. This person says, newly diagnosed, how do you know when you are in remission?
Yeah, that is a really important question, and I wish I had an easy answer for it. The reality is it does depend on the disease, and part of it is it takes some time to figure that out for each individual patient. So in the four examples I gave, out of the four examples, three of the patients still had ongoing symptoms even when they were in remission. And I would say that that's in line with what we typically see in clinical practice. Most patients with vasculitis do have some amount of symptoms still left that represent damage from prior disease rather than ongoing disease. But in the early stages, when we're kind of exiting the initial stage and entering remission, it can be hard to know at what point we've transitioned from the symptoms are from active disease to the symptoms are from damage. And sometimes the only test for that is time and seeing how the symptoms continue to evolve. Um, so that ends up being a conversation with your doctor of, is there still ongoing evidence of active disease? Um, if so, usually they would escalate the treatment, maybe try another course of prednisone, maybe increase the dose of whatever medication you're on. But if your symptoms have been stable for a while, the blood work looks good, no new symptoms are coming up, the medication regimen has been very stable, um, and you still have some symptoms that can be explained by damage from prior inflammation, then that's where we start to kind of transition to think about it as remission with damage as opposed to active disease. So I think it's a great question, and one that there's no easy answer for most people. In some cases, we are able to say, um, that you had all of these symptoms, every single symptom, every lab abnormality resolved, you're off prednisone, you're doing great. And there it can be very easy to identify remission. But I think most cases are not quite that clear cut.
I appreciate that answer. And I just want everybody to know I shared with Dr. Katz earlier that I have recently been in a flare and am now in remission off treatment. But I've had a lot of, 6 years remission, off remission in a flare, and then I had 9 years of no treatment and complete remission, and then it came back to another flare a couple of years ago. So I understand that it's going to be different for every person, and that their doctor has to they need to have their conversation with their doctor, which is what I do. But one of the questions that came in is how long does remission usually last? I know it's such a hard question for you to answer, but we're also finding it to be something that we want to know. And so if you could just help us.
Yeah, yeah, absolutely. And I want to know that too. Um,
Yeah.
so the real answer is we don't know. Only time will tell, and everyone's vasculitis is different. There are some diseases, like I mentioned, like IgA vasculitis, very often anti-GBM disease, polyarteritis nodosa. These are diseases that very often, once they go into remission, in most cases, they stay in remission. So in those cases, the remission we expect or we hope to be lifelong. That is the minority of diseases, unfortunately. The majority of diseases are diseases that do tend to relapse. And how often they relapse, the amount of time between relapses is extraordinarily variable from patient to patient, and also between different diseases. With each disease, there are certain known factors that are associated to be um, risk factors for earlier relapse. So in ANCA-associated vasculitis, involvement of certain organs, having a positive ANCA test, having the PR3 as opposed to MPO, those are all sort of risk factors for having relapse. And the more of those that someone has, the earlier you can expect the relapse to be. But we can't, for an individual person, we can't get precise enough to say, after we treat you with this regimen, we can expect you to be in remission for X number of months, and then you're going to come out of remission. Hopefully, in the future, we will be able to do that. But right now, we can't do that, which is why, for most people, we treat for a certain period of time, and then we either stop treatment or we gradually taper off the treatment, which gives the disease a chance to declare itself and tell us, yes, I do relapse. And this is the amount of time that it takes for me to relapse if I'm off treatment. So it's unfortunately not a clear-cut answer, but there's a lot that goes into it, and there are certain features that you can that help you sort of expect what your trajectory is going to be.
Yeah, I was going to say I have found that to be true, and I have found that trusting my doctor and seeing him every 3 months is what keeps me sane, so that I know somebody's keeping an eye on me. The next question that came in is what imaging is routinely used for GCA?
So the there's two parts to this answer. Um, the first part is in the initial diagnosis and workup of GCA, and the second part of the answer is what imaging is used during remission for monitoring. So in the initial diagnostic stage of GCA, a few different imaging modalities can be used depending on what you're looking for. The most common one is a temporal artery ultrasound, where it's a non-invasive an ultrasound, kind of like a sonogram, that's done of the arteries of the head over here and in the back. And what that's looking for is evidence of inflammation of those blood vessels, which can help support the diagnosis of GCA. Um, that is something that typically doesn't need to be repeated. Sometimes it is to kind of track with the disease activity, but for the most part, we don't repeat that. We really just use that as a diagnostic test. Um, the other type of imaging that's done very often early on in the disease in GCA is to get images of the large blood vessels in the chest, abdomen, and pelvis, because sometimes those can be involved in GCA as well and are very often asymptomatic. So in people where we know that they have involvement of those blood vessels, part of the long-term monitoring approach for those patients will be to routinely repeat that imaging, usually either with a CT angiogram or an MR angiogram, which are dedicated imaging tests that look specifically at the large blood vessels. And we'll do that roughly every 6 to 12 months, just to see if there's any evidence of ongoing inflammation there.
Interesting. Thank you for answering that question. This next question came as a result of your presentation today, but somebody also submitted a similar question in advance. And this one is, what cancer tests are needed if you are on cyclophosphamide? And one person said, what type of monitoring or testing do I need for any cancer while I'm in remission or the length of my disease? So they sort of went together. So I thought I'd give them both to you.
Yeah, and they're important questions. Fortunately, there aren't a lot of extra things that need to be done. Um, even though the risk of cancer related to cyclophosphamide is real, it is fortunately still a rare consequence. It's not something that you can expect to happen just because you've been exposed to cyclophosphamide. The most important thing is to be up to date with your routine cancer screening. So that's things like colonoscopies, mammograms, pap smears, all of the usual, prostate cancer screenings, all of the usual cancer screening that are recommended for your age group and for your sex. You should make sure to stay on top of that. Beyond that, there aren't, to my knowledge, strict guidelines for what is required, but I think many of us do tend to at least check a urine test, a urinalysis, roughly once a year or so. It doesn't need to be exact, just to see if there's any evidence of blood in the urine, because blood in the urine is one of the early signs that might suggest that there's a cancer somewhere in the anywhere from the bladder to the kidneys.
Okay, thank you. Um, this person says, my liver function test has slowly been climbing over the last year, and over the last half year, I've been in remission for 1.5 years. What should I know about why the liver function is going up, and what does the doctor do when he sees it going up, or do they do anything?
Yeah, that's something that we see very frequently, unfortunately, and can range from very benign to forcing us to kind of make changes and go down a whole diagnostic process to see what's going on in the liver. So um, I'd need more information about all of the specifics there, and I encourage you to talk to your doctor about what they think is going on there. But when I see elevations in the liver function tests in someone who's on treatment for vasculitis, the things that I think about are, one, are the liver function tests a sign of the actual vasculitis itself? More often than not, that tends not to be the case. Most vasculitis syndromes don't primarily manifest as elevated liver function tests. But that is the first thing that I think about. Is this the underlying disease? The second thing that I think about is it related to one of the medications? I would say that liver function tests going up, the most common cause that we tend to see that in people who are on medications is medication exposures. And that can be anything from the medications that are used to treat the vasculitis. As I mentioned earlier, we have to check the liver function tests on a regular basis for many of our medications because this can happen. But it can also be other medications, medications that were started maybe for cholesterol problems or an antibiotic that you were on for an infection. All of these things can affect liver function tests. So there's always a consideration of what medications could be causing this. And then the third is there some other process? Because it could be that something else has happened that may be completely unrelated to the vasculitis or to the treatment, and it's an infection in the area, maybe a viral infection that can cause elevated inflammatory or elevated liver function tests, or something else. So there are many potential reasons for liver function tests to be elevated, and I would say the vast majority of the time it's related to some medication. And if that's the case, then it usually means that we need to either reduce the dose of that medication or switch to a different medication. But if it's not that, then something needs to be done to work it up, and see why the liver function tests are elevated.
So it sounds like you're saying to this person that asked the question, it's a great question to ask your doctor. Like,
Absolutely.
why is my liver function going up and when should we worry and what do we do? That sounds like
Absolutely.
their own doctor would be the best answer. Well, thank you for, encouraging us to do that. The next question is, where is research at with B cell therapy?
There is a mountain of research on B cell therapies for many different diseases. In the vasculitis realm, B cell depletion is the is most commonly used in ANCA-associated vasculitis. That's kind of the disease that we think about it most frequently for, but it's used in other types of vasculitis as well. Um, and there is a mountain of research on both the safety of it and the efficacy of it that dates back about 25 plus years since we've been using B cell depletion. We've been using B cell depletion in ANCA-associated vasculitis for about a decade and a half. Prior to that, we were using it in various other autoimmune diseases.
Okay, thank you. I know that's a big topic, and we have done webinars addressing that because it's a big topic. The next question is, this person says, having hip surgery and weaning off prednisone to below 5 milligrams because of PMR. Any thoughts for surgery?
So the way I think about surgery in people who are on either prednisone or other immunosuppressive agents is, first of all, making sure that the timing of the surgery is really thought about carefully. Um, the things that make surgical outcomes worse are being on prednisone, being on immunosuppressing medications that can increase the risk of infection, and having active inflammatory disease, particularly because if someone has active inflammatory disease around the time of the surgery, if they're having a flare, we might need to increase the prednisone to really high doses, which would be much worse for the surgery. And there are also data, not to my knowledge specifically in vasculitis, but in other autoimmune diseases, that having active disease worsens surgical outcomes. So it's always a balancing act of trying to figure out what's the right time in terms of how well the disease is doing, how well the medication regimen is controlling things, and what the risk of around the time of surgery is. Um, if the expectation is that the prednisone is going to be completely out of your system in a few months, then doing the surgery after the prednisone is done is better than doing the surgery on prednisone. That being
Mhm.
said, there's research that shows that once someone's on low doses of prednisone, around 5 milligrams or less, the risk of complications is lower. Still not zero. There's no dose of prednisone that's safer than 0 milligrams. Um, but going from 5 milligrams to 0 milligrams, if it means that the PMR is going to get much worse, then that's the balancing act that I'm talking about. So I think in general, it's a question of how important is the hip surgery? Is it something that can reasonably be put off for a little while? Or is it something that is really interfering with day-to-day life and needs to be prioritized? If it's something that needs to be prioritized, I would say that it's something that can safely be done on 5 milligrams of prednisone. Um, if the only things that we're considering are surgery and prednisone. But there may be other considerations depending on other medical problems, depending on how the PMR has done, whether there's other considerations in your particular case. So it's hard for me to say exactly for one individual person. But for me, what I try to do in patients who need surgery is if delaying the surgery until we can get the disease really well controlled on little to no therapy is an option, then I try to do that. But if it's not an option, then I at least try to optimize things, get them on the lowest dose of prednisone that I can that'll manage their disease. And very often we might pause immunosuppression around the time of surgery just to reduce the risk of infection. So those are all details that are very kind of case by case dependent. And I encourage you to talk with your doctor about that.
Okay, thank you. That was a interesting question, interesting response. I just wanted to ask you, we're getting close to the end of the hour, but do you have another 5 minutes or so? We have about five
Yeah,
more questions.
not a
Okay,
problem.
thank you so much for giving us your time. This one I found really interesting for young children that have GPA, which is an ANCA-associated vasculitis. This person says age 14. Have you taken the child off all medications when in remission, or do you usually keep them on medications for long, like rituximab or azathioprine? Wasn't sure if it's different for children than from adults.
Yeah, so that's a great question. I will say I'm an adult rheumatologist. So my ability to comment on how treating children differently is very limited in that setting. My understanding is that the way it's treated in children is very similar to adults, in that we usually treat for a couple of years, and then after treating for a couple of years, we either taper the treatment or we stop the treatment and see what happens to the disease. My understanding is that it's done similarly in children, but I would definitely defer to a pediatric rheumatology colleague of mine rather than taking me at my word.
Okay, thank you for trying to answer that for us. Um, there are so many questions about remission, and I'm going to ask this one. I know that you've gone over it a little bit, but I think we all are just so unsure of our particular situation. This person says, how can you call it remission if the disease is still requiring immunosuppressives or biologics to keep it under control?
Yeah, so I think that's a really interesting philosophical question,
Yeah.
that's about how we think about autoimmune diseases in general. Um, so unfortunately, most of our diseases don't ever go into remission the way you would define it otherwise, which is most autoimmune diseases are chronic diseases that need long-term treatment to keep them in remission. Um, there are, of course, exceptions, and even in ANCA-associated vasculitis, as Kathy has mentioned, people can go into remission off treatment and then come back out of remission. Um, the ability to actually define that gets much more challenging, because how long do you need to be off treatment in order to call it remission? And ultimately, I think that doesn't really um, that's not what guides our decision making when we're thinking about how to manage the disease long term. Because when we think about remission, we're thinking about, do we have the disease fully under control, whether we're requiring a medication to do that or not. And there are, proposed definitions for what the questioner is suggesting, which is really thinking about remission off treatment, which is an important concept. But it's something that, unfortunately, many patients with vasculitis, it's not even an option because their disease is a chronic disease that if you ever stop the treatment, the active inflammatory disease will come back. So the way we think about it is once we've been able to get the disease under control and aren't requiring high doses of prednisone to do that, then we've done our job at managing the disease and we call it remission. And then if the disease is back and we have manifestations that need to be treated, then they're no longer in remission. I think it's more of a philosophical conversation, and you could make the argument that maybe there needs to be a third term. And
Hmm.
the term that's being proposed is something called long-term remission off treatment. Um, but right now, because that's not something that a majority of people with vasculitis get to enjoy, when we think about remission, the way we think about it is really based on, do we have the disease under control?
And everybody's disease is so different. I've learned it's just a conversation with your doctor. I've had this for 17 years. I had 6 years of pretty active disease on treatment. I had 9 years long-term remission off treatment. First time I'd ever heard that term. And then I had active disease again a couple of years ago. And I just trust my doctor and ask the questions just like you've advised everybody to do today. Um, this next person is saying, GPA, once you stop treatment, rituximab, what is the most common interval for relapse or remission?
I wish there were an answer to that
I know.
question. There is not. Some people with GPA, when you stop the rituximab, the disease will never come back. Some people, it'll come back within 4 to 6 months. Um, and again, there are certain features that can predict a higher or lower risk of relapse or earlier or later risk of relapse. But when I have this conversation with patients, I make sure it's very clear that I do not know if and when they're going to relapse. The biggest predictor of having a relapse is if you've had a relapse before. Once someone with ANCA-associated vasculitis has relapsed, and this is true for most vasculitis syndromes as well, once there's been a relapse, the likelihood that there's going to be another relapse is very high, especially if that relapse wasn't very soon after starting treatment. Um, but beyond that, getting into how long you can expect to be in remission before you come out of remission, I wish I had a clear answer, but we're just not there yet.
Well, and having said that, I'm going to ask you the last question because we have someone that wants to know, is there any research being done on how to prolong remission? Any clinical studies in that area?
Absolutely. I think that's a huge priority of our field. And that's being done with a few ways. One is using the medications that we currently have to try to see what the regimens we should be using are that balance minimizing the immunosuppressive effects and other toxicities from the medicines while also keeping the disease in remission. But also looking at new therapies that have the potential to induce a more prolonged remission. And that's things like there are new B cell targeted therapies that lead to deeper B cell depletion, and the idea behind that is when you deplete the B cells to a greater extent, you might expect the remission to last longer. And there's many others out there. Of course, it all depends on the disease that we're talking about. Um, I'd say most of it is happening. The most research is probably in ANCA-associated vasculitis. Um, but absolutely, this is a huge topic of interest in the vasculitis world. We would love to get to a point where we're able to treat people and get them in remission and not have to depend on really long-term treatment to be able to keep it that way.
Well,
That is a
thank
work in
you.
progress.
Yes, I know we would all love to know that. So thank you so much for answering that and for letting us know that there is some work towards that in our future. Just before we finish up today, I just want to share a few things with everyone. We want, sorry, one second here. We want to let you know and remind you about the Vasculitis Foundation website. You can find all kinds of information there. For instance, under education, you can learn more about the particular form of vasculitis that you have and that a loved one might have. As a matter of fact, you can read about it, all about your form, and then you can go to the resource print tab and actually print out something that you can take with you to a doctor's office. I tell everyone I just did this, taking it to my dentist who was not very familiar with my form of vasculitis. Also on the VF website, you'll find a video library with all of the recorded webinars. So everything that, like what you've seen today. And on the homepage, you can find out more about the patient support groups, upcoming events like live webinars, as well as the Vasculitis Foundation conferences that are coming up. And having said that, I just want to also tell you that there's a new Find a Doctor database on the Vasculitis Foundation website, and I'm very excited about it, so I'm going to tell you about it. You can do a search of healthcare providers with experience who in diagnosing and treating vasculitis. You can click on the Find a Doctor button, and it will take you to a step where you can enter your location and any filters like what type of doctors you need to see so that you can find the right kind of provider for your form of vasculitis. And speaking of conferences and upcoming events, I just want you to know about two in-person events that are coming up. Um, Please consider attending on October 11th. The Penn Vasculitis Center in Philadelphia will host their 2025 patient education meeting. And I understand you can still register for that, and that's in Philadelphia. And then on November 1st, the Vasculitis Foundation is hosting the next Vasculitis Foundation Regional Conference at the Medical University of South Carolina in Charleston. And I plan to be there, so I'd like to meet you if you come there. And I think the weekend after that, if I'm not crazy, there's one in New York. And then I also just wanted to, of course, say thank you so much to Dr. Katz for his time that he spent with us today. Sorry, my screen keeps blipping. There's a survey that's going to pop up when you leave today, and we really want you to take that survey. So when you see the button that says continue, please click on that. If you can help us by taking that survey, then we will know more about what kind of webinars you'd like to see in the future. It just helps us know how to guide our choices in the future for the Vasculitis Foundation webinars. And of course, I need to say thank you to the Vasculitis Foundation for providing these webinars and to our sponsor, Novartis, for supporting the educational webinars of the Vasculitis Foundation. And Dr. Katz, so many people commented at how much they appreciate your time and what a great presentation it was. So thank you so much for spending your time with us today.
Thank you. It was a pleasure.
Okay, goodbye, everyone.